Dear colleagues, welcome back on our weekly session on EOS and ERCP. And this time we have a very eminent name. You have been listening to him and you have been watching him on Facebook on his face page, where he regularly uploads very interesting videos that he does in Cairo University in Egypt. He's a great friend, Professor Hussein Okasha. He's going to guide us on how to stage a person suffering from adenocarcinoma of the pancreas. And all yours, Professor Hussein. Thank you, Professor Hussein.
Yes, yes. I will start sharing the screen.
Great.
Okay. Now the screen is clear for you.
Yes, perfect.
First of all, I'd like to welcome all my colleagues in Pakistan, in Cairo, and everywhere, and like to thank you very much for your interest in endoscopic ultrasound. And I'd like to especially thank Professor Ghiyasun Nabi Tayyib and Professor Muhammad Khalid Hassan for their kind invitation for their very prestigious gastroenterology society in Pakistan. Today, I will talk about a very important and very essential subject in the field of endoscopic ultrasound, which is the role of endoscopic ultrasound in staging of malignant pancreatic masses. Malignant pancreatic masses, as we all know, may be an adenocarcinoma, cystic pancreatic neoplasms, neuroendocrine tumors, lymphoma, or metastasis. The commonest malignant lesion of the pancreas is, of course, pancreatic carcinomas, and the commonest type of pancreatic carcinoma is ductal adenocarcinoma, which accounts for about 90% of all pancreatic carcinomas. Pancreatic carcinoma may also be acinar adenocarcinoma, mucinous cyst adenocarcinoma, intraductal papillary mucinous neoplasm, serous cyst adenocarcinoma, pancreatoblastoma, especially in children, solid pseudopapillary tumor, Spen or Franz tumor, and the rare osteoclast like giant cell tumor. Pancreatic cancer constitutes about 3% of all new cancer cases in the United States. The number of new cases of pancreas cancer was about 11 per 100,000 per year, and the number of deaths is high. It is about 11% per 100,000 per year. The number of cases have been rising on average of 0.8% each year over the last 10 years. And unfortunately, the 5-year survival is ranging between 5 and 7%. Only the 5-year survival is 5 to 7%. So it is a very aggressive tumor. We all know that the only real hope for cure is radical resection. So early diagnosis of cancer pancreas and proper staging of cancer pancreas is the only hope to improve this very low 5-year survival. So just after the diagnosis of cancer pancreas, the surgeon always asks the endosonographer this question: is it resectable? Is it operable? But before you have an accurate decision of surgery, you must have an accurate staging. So let us talk about staging of the pancreatic cancer. The staging of pancreatic cancer is based on the classic TNM system: T for tumor, node, N for node, and M for metastasis. We all know that. And in addition, we should determine the resectability of the mass. We should write a word in the conclusion whether the mass is resectable, borderline resectable, or unresectable. Let us talk about the classic TNM classification. This is the old one issued in 2010. T1 is tumor limited to the pancreas and smaller than 2 centimeter. T2, tumor limited to the pancreas and larger than 2 centimeter. T3 are tumors extend beyond the pancreas but without involvement of the celiac axis or the superior mesenteric artery. And T4 are tumors involves the celiac axis or the superior mesenteric artery. And N0 for no regional lymph nodes, and N1 for the presence of regional lymph node. In 2017, there is a slight modification of the previously mentioned old one. In the lymph nodes, N0, no regional lymph nodes, N1, metastasis in 1 to 3 regional lymph nodes, and N2 is metastasis in 4 or more regional lymph nodes. And regarding the local T staging of the tumor, T1 is the same, tumor limited to the pancreas and smaller than 2 centimeter. If it is less than half centimeter, then it is T1A. If it is from half to 1 centimeter, then it is T1B. If it is between 1 and 2 centimeter, then it is T1C. And the T2 is the same as the old one, tumors between 2 and 4 centimeters in the greatest dimensions. Here, T3 differs. T3 here, the tumors more than 4 centimeter in the greatest dimension. So from T1 to T3 depends on the size of the tumor. But T4 here, stated for tumors, involves celiac axis, superior mesenteric artery, and or common hepatic artery, regardless the size. Here, this is, I should stress in the term involves. What is meant by a vessel involved by a tumor? How the tumor involve a vessel? Is it by touching the vessel, or the presence of irregularity of the vessel at the site of the tumor, or the vessel is occluded, engulfed, pinching of the vessel, extending into the vessel, compression, narrowed, displacement, and so on, teardrop invasion? But all that are right, but I think the most suitable point to determine vessel invasion is loss of the normal interface between the vessel and the tumor. This is an example of the normal interface between the vessel and the pancreatic tissue. This white line is the interface between the pancreatic tissue and the vessel. Here it is a splenic vein as seen by linear endoscopic ultrasound. And here, this is a very nice interface. This is white line between the portal venous confluence. This is a very nice interface between the vessel and the normal pancreatic tissue as seen by radial endoscopic ultrasound. This short video shows very nicely that a very clear line of cleavage between the vessel and the mass. This is very nicely well-localized pancreatic body mass, and this is the venous confluence. And you'll notice here that the interface between the vessel and the mass is very clear. It is whitish, it is uninterrupted, it is continuous, no compression, no invasion. Yes, very nicely seen. Yes, very nice, very nicely seen line of cleavage between both. But here we notice that there is a marked irregularity of the vessel wall at the site of the tumor. This is a pancreatic head mass, and this is the portal vein. And here we notice there is irregularity of the vessel wall and loss of the normal interface. So this vessel is involved by this mass, by this pancreatic head mass. And here this is a large pancreatic body mass invading the celiac trunk. This is the aorta, and this is the uptake of the celiac axis. And here, this is the celiac axis, very clearly that it is compressed, irregular outline, and loss of the interface between the large mass and the vessel. And here, this is even invasion of the celiac trunk by the mass. Here, this is intravascular extension of the nearby mass. It is not a thrombus, maybe a thrombus, but mostly it is invasion because the texture of this area inside the vessel is the same as the texture of the mass. So mostly it is part of the mass with actual invasion. So it is very important to determine if the vessel is involved by the mass or the mass is away from the vessel. After we know the classic TNM staging, it is very important from the clinical point of view to mention that the mass is resectable or borderline resectable or unresectable. Resectable tumors should be referred directly for curative surgery in surgically fit patients. Borderline resectable tumor can be considered for neoadjuvant chemotherapy or radiation or both for downstaging, then possible resection with or without vascular reconstruction, or metastatic or unresectable tumors that should be directed to palliative chemotherapy. So the surgeon or the referring doctor or the attending doctor is waiting in the conclusion to see the stage of the mass and whether the mass is resectable, borderline resectable, or unresectable, because this will lead to determine the plan of further management. Then how to determine the resectability of the tumor? To determine the resectability of the tumor, we should stress or know three important points. The first point is which vessel is involved. Is it the aorta, celiac axis, superior mesenteric artery, superior mesenteric vein, portal vein, or portal venous confluence? Which vessel is involved? The splenic vein, for example, or the splenic artery, if it is involved, no matter. It is not important at all. I can remove the spleen and remove the splenic vessels. But aorta is very serious. Celiac axis is very serious. Superior mesenteric artery, slide a little bit less. So determination of the involved vessel is very important. This is the first point. The second point is the pattern of involvement of that vessel. Is it abutment or encasement? And we will know later on what is the difference between abutment and encasement. And the third point is the length of the involvement of the vessel. This is especially for venous structures, especially the superior mesenteric vein, portal vein, or confluence between superior mesenteric and portal veins. What is the difference between encasement and abutment? Abutment is involvement of less than 180 degrees of the circumference of the vessel, less than half of the circumference, less than 180 degrees of the circumference, while encasement is involvement of more than half of the circumference or more than 180 degrees of its circumference. If there is a vessel, if this is a vessel and this is the cancer, then the cancer is involving less than half of the circumference of the vein. Then this is abutment. But here it is involving more than half of the circumference. Then it is encasing this vessel. This cancer is encasing this vessel. This is an example of abutment. This is a large mass, but involving less than half of the circumference of this vessel, which is the superior mesenteric vein seen from the bulb of the duodenum. And here, this is the same patient. The mass is present in one side of the vessel. Yes, but here there is no mass, so it is involving one side of the vessel, less than half of the circumference of the vessel, or less than 180 degrees of the vessel. But here we notice that there is total encasement, involvement of more than half and even the whole circumference of the vessel. This is a large pancreatic body mass, and this is a celiac trunk, and this is the celiac trunk, and totally encased by the mass. Yes, very nicely seen. Yes, this is the large mass, and this is the celiac trunk inside this very pancreatic body mass. So it is a very serious situation. It is encasement and not abutment. So after knowing these 3 points, we can determine or can easily pick up the borderline resectable mass. The mass is borderline resectable if there is superior mesenteric artery abutment for less than 180 degrees. If there is encasement of the superior mesenteric artery, then this mass is unresectable. And if the superior mesenteric artery is free, then it is a resectable mass. So superior mesenteric artery is a very important vessel. If it is free, then the mass is resectable. If there is abutment of the superior mesenteric artery, then the mass is borderline resectable. And if there is encasement of the superior mesenteric artery, then the mass is unresectable. Regarding the common hepatic artery, if there is short segment abutment or encasement, but with no extension to the celiac axis, there is 1 centimeter free between the common hepatic artery and the celiac axis, then it is borderline resectable. if the tumor involving the whole length of the common hepatic artery till or including its origin from the celiac axis, no 1 centimeter free, then it is unresectable. And if the common, of course, if the common hepatic artery is not involved, then it is a resectable tumor. If there is encasement of the gastroduodenal artery up to the hepatic artery, then it is a borderline resectable. Very important to study the superior mesenteric artery and the portal vein. If there is abutment, encasement, or short segment venous occlusion, but with suitable vessel proximal and distal to the area of vessel involvement, allowing for surgical resection and reconstruction, then it is a borderline resectable tumor. This distance is judged by the surgeons to be about 2 centimeters. So if these vessels are involved, whether by abutment, encasement, or occlusion, but less than 2 centimeters, then you can do approximation of the edges of the vessels with suturing or vascular reconstruction or something like that. If it is less than 2 centimeters, then it is borderline resectable. But if the distance of the involvement is more than 2 centimeters, it is very difficult to do vascular reconstruction. But this 2 centimeters is a subjective distance. It is not stated here in the determination of borderline resectability. It is left to the circumstances of the operation. I asked my eminent surgeons in Cairo University about this. They are saying that 2 centimeters is suitable or less, but it depends on the tributaries. If the mass is involving more tributaries of the superior portal vein or the superior mesenteric vein, or if there is no collaterals around, circumstances is unsuitable, then it deemed unresectable. So 2 centimeters agreed by most of the surgeons, but this is a subjective, and it is left finally to the circumstances intraoperatively. And of course, to be borderline resectable tumor, the celiac axis is free, except in M.D. Anderson, as I will mention later. But the celiac axis, aorta, and inferior vena cava should not be involved either by abutment or encasement. Let us see some of the videos which may make things more clear. This is a large pancreatic head mass. Yes, this is a large pancreatic head mass, and this is a plastic CBD stent. And we notice that there will be also a pancreatic stent. I don't know why, because it is a referred patient. It is not my patient. Yes, and this is a large pancreatic head mass. Yes, and here we can see very nicely the portal venous confluence. This is the portal vein, and this is the superior mesenteric vein. Here, the line of contact is unclear, so the vessel it is involved. This vessel is involved because the line of interface, or sometimes called the line of contact or line of cleavage, is not clear. So this vessel is involved, and the distance of involvement is about 2 centimeters or less. So it is a borderline resectable mass. If this distance is more than the distance of contact or involvement of the vessel is more than 2 centimeters, then it is unresectable. But here I think it is less than 2 centimeters. Let us see this video. It is also of borderline resectable tumor. Yes, this is a pancreatic head mass, as well seen from the bulb of the duodenum, malignant looking. And this is the portal vein, and this is the splenic vein coming from below and the left side of the screen to join the superior mesenteric vein to form the portal vein. And here there is the line of interface between the mass and the portal vein is unclear, so the vessel is involved, but the length is not too long. I think it is less than 2 centimeters. This is the mass, and this is very nicely seen. This is the venous confluence, and here the line of interface is completely lost. Here it may be clear, somewhat clear, the line of interface, but here the line of interface is completely lost. So this is a borderline resectable tumor. Some surgeons, very competent surgeon, experienced surgeon, can go for that and do vascular reconstruction. But most prefers to refer the patient for a neoadjuvant chemotherapy for a more easier operation and better outcome regarding regarding the recurrence of the tumor. This is abutment of the superior mesenteric vein. Abutment is involvement for less than 180 degrees. This is a large, yes, very nicely seen, a large pancreatic body mass. And here, this is the superior mesenteric artery arising from the aorta. This is the abdominal aorta as seen by the linear echo endoscope while in the stomach subcardial. And this is the uptake or the origin of the superior mesenteric artery. And above it will be the uptake of the celiac axis. Here, the superior mesenteric artery is abutted by this large mass. The mass is present, yes, the mass is present at one side of the tumor, while here there is no mass. So the mass is involving less than half of the circumference of the superior mesenteric artery. So it is superior mesenteric vein is abutted very nicely. So it is a borderline resectable tumor. Here, this is the abutment of the or encasement of the common hepatic artery. This is the celiac trunk, and this is the common hepatic artery. If there is 1 centimeter free of tumor between the common hepatic artery and from its origin from the celiac trunk, then it is borderline resectable. But if the mass is involving the whole length of the common hepatic artery till its origin from the celiac trunk, then it is unresectable tumor. I hope that will be working, inshallah. This is the previous video. This is the aorta. And here, very nicely seen celiac axis. This is the superior mesenteric artery, and this is the celiac axis originating just above the origin of the superior mesenteric artery. It is compressed and totally encased by the mass. When I want to demonstrate the common hepatic artery, I can do anti-clockwise rotation to demonstrate the common hepatic artery as it arises from the celiac axis. Yes, this is the celiac axis. I will do anti-clockwise. Yes, this is celiac axis coming from the aorta. Yes, when I do anti-clockwise, yes, exactly. Do anti-clockwise, then it is a common hepatic artery. So the common hepatic artery, the whole length of the common hepatic artery is involved or encased by this large mass from its origin till its end, and even the celiac axis is involved. So these patients, of course, is unresectable. There is no 1 centimeter free of tumor at the origin of the common hepatic artery. And it is very nicely seen common hepatic artery going down to the left and right side of the screen towards the porta hepatis to join the liver at the porta hepatis. Yes, and this is arterial pulsation, but due to marked stenosis by being compressed by a mass, so there is shadowing and hazing of the color flow wave. And this is the gastroduodenal artery, encasement of the gastroduodenal artery, and it's very easy to pick up the gastroduodenal artery because it is very near to the echo endoscope, while in the upper second part of the duodenum, this vessel is very near to the echo endoscope, while the superior mesenteric vessels are away. This is the superior mesenteric vein, superior mesenteric artery, and this is the gastroduodenal artery. Yes. So by these videos, we can finally determine the degree of resectability of the mass. Yes, whether it is resectable, borderline resectable, or unresectable. To repeat again, borderline resectable tumor are tumors that first abutting the superior mesenteric artery, abutting or encasing the common hepatic artery, but there is 1 centimeter free of tumor from origin protrusion from the
Mr.
celiac
Hussein, your
axis.
slides are not moving. We cannot see your video. What is your take on putting stents in a person who is suffering obstructive jaundice? Stents in the pancreatic duct, stents in the biliary channel?
So I think we should wait on maybe what Dr. Professor Hussein Okasha has to say. But usually, if it is resectable, and we are not planning for any neoadjuvant therapy, in that case, we try to avoid stenting those patients and send them straight for surgery. If, however, it is considered borderline resectable with high bilirubin, and in those cases, especially in our setting, our oncologists, they want bilirubin to be less than for neoadjuvant therapy. So in those cases, and we will place a biliary stent, and usually would place a metal biliary stent. So that's our practice. I don't know how it is in Egypt, and usually that's the course we follow. What about in Pakistan?
In Pakistan, I think since majority of patients, they first land with the radiologist and then they come to the gastroenterologist. US is always taken up later, the practical situation. So in that scenario, most of the time when a gastroenterologist sees that the duct is obstructed, it puts in a stent. Now the question is, do we need to, what should be the threshold of bilirubin? It should be more than 10, more than 15. Obviously, there's certain absolute indication that the person's septic, person's having cholangitis. We definitely have to drain. But otherwise, in the absence of infection, what will be your threshold? And if the guidewire goes into the pancreatic duct, we'd like to put in a stent there too.
So these are multiple questions, multiple scenarios. So first, if, as I mentioned, if it is resectable and even bilirubin high 10, even up to 15, as long as it is deemed resectable in those and no cholangitis and no other multi-organ disease, which is going to delay the surgery, in those cases, we try not to intervene. In again, if we're going to consider neoadjuvant therapy, then in that case, we'll go ahead and place a stent. And now question comes, like if you go into the pancreatic duct and would you put a stent in there? So from our experience, we know not that these patients don't develop a pancreatitis, but from our experience, we know these patients are the ones who are very low risk of developing a post-ERCP pancreatitis. Routinely, I do not. There is some evidence that some of these patients actually may have a symptomatic improvement if you place a pancreatic stent. So routinely we do not in case if a wire goes into the pancreatic duct, I would not.
Good. So Professor Okasha is back with his computer again rebooted.
Sorry for that. It occurs every now and then that the internet connection is not so nice. So sorry for that. And we back again. Yes, now the video is clear for you. Yes. Now the screen is now clear.
Yeah, we can see the screen very clear.
Yes, this is the last video. Here, the celiac axis and the aorta and the IVC should not be involved. This is a large pancreatic body mass abutting the superior mesenteric artery. So it is still now, it is borderline resectable. But as I told you before, it is involving the celiac axis, so it is unresectable mass. So these are the most of the societies of cancer societies agreed for all what I have mentioned before, with a little difference regarding MD Anderson. MD Anderson is a very big society in the United States, It agrees with all other societies, but a little difference is that it considers abutment of the celiac axis by a pancreatic body, not pancreatic head, by a pancreatic body pancreatic body mass renders it borderline resectable and not unresectable. So all societies stated that any involvement of the cancer of the celiac axis by the cancer, whether abutment or encasement, it is unresectable, except M.D. Anderson. It is stated that abutment of the celiac axis by a pancreatic body mass renders it borderline resectable, and we may try new adjuvant chemotherapy for possible down staging of the mass and further radical resection later on. Now, after staging the mass and determining of its resectability, I wonder, and I hope that it is more clear now, remaining two important points which should discuss before the end of the lecture. The first point, which is better in staging of the cancer pancreas, the radial echo endoscope or the linear echo endoscope. There is no enough evidence to show a difference in the accuracy between linear and radial probes in cancer pancreas staging. But keeping in mind the possible need to perform EUS-FNA as a diagnostic tool, so the use of linear probe would be more suitable. And I believe that the major advantage of linear echo endoscope is the ability to obtain instantaneous, immediate, safe FNA of pancreatic masses or any other masses. Then what is the weight of EUS in the cancer pancreas staging compared to CT or MRI? 11 well-designed studies compared EUS and CT for the pre-operative staging of cancer pancreas, and the results as follows. Regarding the T-stage accuracy, 4 of 5 studies concluded that EUS was superior to CT, and EUS was also superior to CT in staging. Regarding comparison of EUS and MRI, both are equivalent for any staging and vascular invasion. It was showed that for any staging, the MRI has a sensitivity of 15% and specificity of 93. EUS has a sensitivity of 36% and specificity of 87%. Regarding the vascular invasion, MRI has sensitivity of 59% and specificity of 84%, and EUS has sensitivity of 42% and specificity of 97%. So, EUS has a very heavy weight in staging, evaluation of vascular invasion and resectability, and of course, the ability to do instantaneous, easy, and safe tissue sampling. This is my last slide, but I like this algorithm very much. It is very simple and very informative algorithm for detection and staging of cancer pancreas. First, we do multi-detector CT scan or MRI because it is non-invasive, no propofol, no sedation. It is a non-invasive method, though it is not the most accurate method, but it is non-invasive method. So we start with CT scan or MRI. If the CT showed a pancreatic mass that is clearly unresectable, then we do ERCP if there is hyperbilirubinemia, and very important to do EUS-FNA to obtain proved histo or cytopathological proof of malignancy for palliation, for chemotherapy and palliation, and of course celiac plexus neurolysis if there is pain. If CT showed pancreatic mass which is clearly resectable and the patient is fit for surgery, the patient should be sent for radical surgery because it is the only hope, of cure. If the CT showed equivocally resectable tumor, it is not clear whether it is resectable or non-resectable or borderline resectable, we should do the more accurate method, which is endoscopic ultrasound. If the endoscopic ultrasound demonstrated a resectable mass, then it should be sent for surgery. If it shows unresectable mass, then we should do FNA for a palliation, for chemotherapy and palliation. If the CT showed no pancreatic masses or equivocal pancreatic masses, especially in cases of obstructive jaundice, we should go to the more sensitive, more accurate endoscopic ultrasound. And again, if there is a resectable mass, then it should go for surgery. And if it is non-resectable mass, then we should do FNA for chemotherapy and palliation. This is a very simple algorithm, very informative for detection and staging of pancreatic mass to determine further management. Now we come to my conclusion. It is very important to stage borderline resectable pancreatic tumors for possible neoadjuvant chemoradiation, for down staging and possible vascular reconstruction during radical surgery. EUS, multi-detector CT, MRI are the available tools for tumor staging. However, the possibility to obtain samples from suspicious lesions or lymph nodes by means of EUS FNA makes this procedure an ideal diagnosing and staging modality for pancreatic cancer. And again, I'd like to thank you again, the Pakistan Society of Gastroenterology and Endoscopy for their kind invitation. Thank you, or merci in France, or danke in Germany, or tashakkurat in Turkey. I wonder if the Pakistan language is present here. If present, then thank you again. And if not present, please send it to me to put in the last slide. Thank you, and hoping to meet you again. And I am ready for any discussion.
Thank you, Professor Hussein. It's very much there. You have written Aapka Shukriya. It's right there just above your name. On the, if we look at the screen on the right of the minaret that you've shown.
These Arabic alphabet, right there, the last one on the right is Urdu, which is Pakistani.
Arabic script, they just do the Shukra and Aapka Shukriya. These are two things. Well, thank you very much. That was a very nice lecture. That was a very nice presentation. Made the concepts pretty clear. And your algorithm was very precise and to the point that those who are clearly unresectable on CT scan, they don't need to go for EUS. Those who are clearly resectable, again, they don't need to go for EUS unless we want to have the biopsy. It's only the unequivocal where the best utility of EUS is there. And I'm raising this point in particular for the reason that in Pakistan, there are not many centers where EUS is available. So the best utility of EOS should be clear to each and every one. And number one, to take the biopsy. Number two, to evaluate those cases where it is equivocal or where the CT scan fails to pick a particular reason for the obstructive jaundice. The house is open for discussion.
Can I comment on that algorithm a little bit?
Yes.
So if we go back to slide that algorithm really, I think, applies to adenocarcinoma. That does not, there are other type of obviously cancers like a neuroendocrine tumor, which could be non-functional. There could be a lymphoma as well, even though the incidence is low. In our center or in the United States, majority of these patients, especially it used to be that, oh, you look at the mass, it looks resectable, and there's no vascular involvement, and they are within the pancreas, they need to go for surgery. But lately, now what's happening, some of these are non-functional neuroendocrine tumor being diagnosed in an 80 years old gentleman or a woman, 80 years old patient. In those cases, even though they may be fit for surgery, is it really right thing to do for them? If they have a non-functional small net in there, maybe a 1 centimeter. So many times those are just observed. So in our practice, many of those end up getting a EUS before going for surgery or being considered for surgery. So just wanted to comment on that. This algorithm is basically applicable to adenocarcinoma, where you see a ductal dilation, post-obstructive ductal dilation, because that usually does not happen with the lymphoma. Some characteristics. You look at it, it's an irregular border. It's not very round border, which can happen with a neuroendocrine tumor. There may be a little bit cystic degeneration of those. A tumor like those, they are the one we need a further evaluation with EUS before going for surgery.
I totally agree with you. Very, very nice comment, but I want to add something very important, that we can do radical surgery and finally we find autoimmune pancreatitis, especially type 1 autoimmune pancreatitis, IgG4 related disease. So in many countries, including Egypt, surgeons emphasize and stress on obtaining FNA of any tumor, of any mass-like structure in the head of the pancreas before radical surgery, before they stress on that, in contrast to this algorithm. Because in the Scandinavian countries, studies coming from Scandinavian countries mentioning that about 10 to 15% of surgically resected pancreatic head during pancreatic duodenectomy turned to be autoimmune pancreatitis, in addition to non-functioning neuroendocrine tumor, as you exactly mentioned. I asked many of the European countries and Turkey and Giovannini in France and Hakan in Turkey. And I surprised that most of the countries, even the European countries, now incorporating FNA for resectable tumor to avoid doing unnecessary major operations with high morbidity and mortality for benign diseases or nearly benign diseases like autoimmune pancreatitis and lymphoma and non-functioning neuroendocrine tumor. And I think the US journal, the issue before the previous one, Anand Sahai from Montreal, issued the algorithm for Canadian algorithm from Montreal followed by Anand Sahai, and they stressed only and changed the algorithm to have EUSFNA from resectable pancreatic tumor before radical surgery. What do you see about that? Dr. Khalid?
Yeah, so I did not see that algorithm by them, but I think I agree. In our practice, it's same too. Before you put these patients through radical surgery, nowadays where these patients are going through EUS and FNA, again for the same reason as you mentioned, autoimmune pancreatitis, non-functional neuroendocrine tumor, lymphoma, even though the percentage of those is not high, but still, I think EUS FNA adds a lot of information, especially when it's unequivocal that like it's not really a straightforward answer. In those cases, EUS is very, very helpful.
Okay, what is your practice in Pakistan, Professor Ghaisun Nabi?
Well, in Pakistan, most of the time the patients present pretty late. And that's another very important query that I should like to raise. A case who is clearly unresectable on CT or MR with tumor markers pretty high in thousands. Still, will you like to go for US FNA in a person who is above 70 with lots of comorbidities?
Yes, this is yes. In Egypt, it is now a usual everyday practice to take FNA from from resectable, even from resectable tumor.
Unresectable large tumor with high tumor markers.
Yeah. This is another question. Yes. Some of the chemotherapists in oncologists in Egypt may give chemotherapy. You are meaning that? Yeah, really. Oncologists in Egypt, some of the oncologists giving chemotherapy based on the very high CA19-9, but it should be higher than 1,000. Should be higher than 1,000 international unit per liter. Should be like that, without the need of FNA.
So you're not going to do biopsy in those cases where it is clearly unresectable, and the tumor marker is more than 1,000.
Yes, 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 but not all oncologists following this policy. Not all the, but I know that some of the oncologists do not need FNA if the US picture is highly impressive of pancreatic carcinoma, irregular outline, give the impression of pancreatic adenocarcinoma. So just he's telling me if it is unresectable, don't do FNA because the CA19-9 is very high, more than thousands. But the patient should not have obstructive jaundice or cholangitis. This should
In
be interpreted. 1000 CA19-9 should be interpreted in the presence of normal bilirubin level, like in malignant pancreatic body or malignant pancreatic body mass, because CA19-9 may be as high as many thousands in cases of cholangitis or obstructive jaundice. So if a
That's right.
patient is not jaundiced and have CA19-9 more than 1000 unit per milliliter, they do not need, many of them not need FNA, but others, they should stress on FNA because of medico-legal issues.
That's right. In Pakistan, majority of the oncologists want the tissue diagnosis, may it be through the US, may it be CD guided, but they prefer to have tissue diagnosis, confirmed tissue diagnosis before they
Yes,
start the chemotherapeutic
yes,
agent. What is your
yes.
protocol to follow these patients, the ones who are on neoadjuvant therapy?
That
Do you follow
protocol, the
them with
protocol is
US or
put
you
by,
follow them with the CT and MR?
yes, yes, yes. A protocol was put by the oncologist. I noticed that the oncologist giving 6 cycles of gemcitabine, I think, and these 6 cycles, and after 6 months of starting chemotherapy, and these 6 cycles, they send the patient again for reassessment. Those for borderline resectable patients.
So what is your
They give,
assessment tool? Do you assess them with the CD scan, or do you assess them with MR, or do you assess them with US?
no, EUS. EUS and PET scan. EUS and PET scan. They are
US.
now in Egypt believing that the most accurate is endoscopic ultrasound, most accurate than CT and MRI. But PET scan should be issued because a large part of the tumor may be dead, no activity, and still is not decreasing in size. So the response to neoadjuvant chemotherapy is not only decrease in size, but decreasing the activity on PET-CT. The SUV max when returns to normal, even in the presence of a mass, because EUS can see the mass, but cannot know if the mass is necrotic or became inactive. EUS cannot judge that, even by the vascularity, because as you know that duct adenocarcinoma is very hypovascular from the start, even aggressive duct adenocarcinoma is hypovascular. So you can't judge the response of chemotherapy and the activity of the mass by EUS. So after 6 months, they do endoscopic ultrasound because they are believing that it is the most accurate modality, more accurate than CT and MRI. And of course, PET scan, they are doing PET scan to have. Sometimes I found after 6 cycles of chemotherapy and after 6 months, I see minimal decrease in the size of the mass compared to 6 months before. But the PET scan are saying that there is no activity. Now the tumor is dead, but still there. So it is very important to combine EUS and PET scan in cases of neoadjuvant chemotherapy for downstaging for possible radical surgery later on.
Professor Hussein, what's your experience in T1, T1A, T1B tumors with RFA? Do you do them? Do you do the RFA for these smaller than 1 centimeter size tumors?
Yes, yes. We did till now 7 cases of EUS guided radio frequency ablation by EUSRA of Taiwan. But for small adenocarcinoma, we did only 2 cases of adenocarcinoma, and this is not the standard of care. The standard of care is surgery. But we did this in 2 patients because they are surgically unfit patients. It is very old age, and unfit for surgery. And one of the tumor is about 11 millimeter, and the second is about 17 millimeters. So both are less than 2 centimeter. Then it is T1 tumor, and the presentation, one of the presentation of the patient was pain, and the other it was located in the body of the pancreas near the celiac plexus, and the other is compressing the pancreatic duct with accidental discovery of pancreatic duct dilatation during routine ultrasonography. And the response was really very good, but only 2 patients. 2 patients is very small number of patients to judge, but the other 5 patients was applied US radiofrequency ablation, applied for 5 cases of insulinomas, which is very effective in insulinoma. And now it is maybe later on it will become the standard of care because insulinoma, as you know, a very benign tumor, very rare to produce metastasis. So if you burn 80% of the volume of the insulinoma, then you get rid of 80% of the problem of the patient, and you can do it second or twice. That is in contrast to duct adenocarcinoma. If you leave 1% of the tumor, then the tumor will, the very aggressive tumor will grow again. So radiofrequency ablation for T1 and T2 pancreatic adenocarcinoma should be done only in surgically unfit patient, and as I think till now as a palliative maneuver, not for cure, because you can't ablate 100% of the surface because will burn nearby normal pancreatic tissue, and this is very serious. But in insulinoma, if you burn about 80% and you have a nice safety margin from the normal pancreatic tissue, then you can get rid of 80% of the complaint of the patient. In an early benign tumor will not grow again rapidly and will not send metastasis. So very nicely applied to insulinomas and not duct adenocarcinoma, except in surgically unfit patients.
Nadeem, you wanted to say something?
What?
Thank you, Professor Tayyib. Professor Okasha, thank you very much for an excellent talk. I have a comment and a question for you. The question is, the question that we get asked by our surgical colleagues is about the conventional or unconventional arterial anatomy. Now, obviously, I can see in your hand, despite EUS being a 2D modality, you're able to accurately stage the cancer. So question is, how confidently can you answer the question whether a patient has a conventional arterial anatomy or not? For example, the cases where they have a replaced right hepatic artery. Another question, obviously, that I think that we've learned over the years is whether the patient has this median arcuate ligament syndrome, celiac artery stenosis or not. So those are the important consideration when the information is being provided to surgical colleagues, especially when they're making a decision for a very high risk surgical modality. And the comment, I think, in terms of the algorithm was, I agree, I think EUS should come before any invasive intervention, especially endoscopy intervention of ERCP, as there are cases where an ERCP intervention could convert a resectable cancer into an unresectable cancer. But fantastic talk, and thank you very much.
Yes, regarding the question, you are very right. The accuracy of endoscopic ultrasound in staging is 85 to 90% in best hands. So there are wrong staging in about 15%. And this is also for CT and MRI. So you are totally right. But I think this is for hepatic artery is slightly a little bit more difficult to stage the hepatic artery, because the common hepatic artery is rather difficult to visualize from the duodenum, from the duodenal bulb. It is better to visualize from the stomach, and you should do a hard job of tracing the celiac axis from the aorta, and then common hepatic artery, and then its bifurcation into gastroduodenal to the left of the screen, and the hepatic artery proper to the right of the screen. So I think the hepatic artery is a little bit difficult, but screening visualizing the superior mesenteric artery is much more easier. Portal venous conference is much more easier. You can visualize it from the bulb of the duodenum and the stomach. And but you are totally right. Overall, at the end, the accuracy of EUS staging is about 85%. But you are deceived by the very huge Japanese fighter that is not 100%, of course. But you are totally right. You are totally, even in best hands, the accuracy of EUS in staging is about 85 to 90%, especially in common hepatic artery and the hepatic artery proper.
On the same lines, the way we in United States we say is like EUS and CT scan, they are really complementary to each other,
yes,
combining both give you much better staging as compared to either modality alone. EUS is two-dimensional. In CT, they are making a lot of progress. Technology is making a lot of progress. They can reconstruct the images. And CT sometimes does better at especially arterial involvement or arterial evaluation. Where EUS still does much better job is the portal vein, confluence, and SMV, because that is still in our domain. Of EUS, we can take a really better look at that. Not that we can't do a good job at SMA or celiac, but I think at the end of the day, advancement in technology has brought CT either very close or maybe even ahead in certain circumstances with regard to staging. So for us nowadays in the United States, we do comment on vascular involvement, what do we say? But it really is a combination of the CT scan and EUS to have the final staging of the patient.
Yes.
It's a question to all the panelists. A very common scenario, that's the reason that I was asking Saad is there. Most of the times in Pakistan, patient comes with a report of ultrasound with a bilirubin.
Yes, I am there.
And we do a CT scan on day 1, and on the following day, we are expected to do ERCP. Saad, isn't it a common scenario?
Yes, Vyas. And it depends and varies from the surgeon to surgeon, I think. This is what I suggested there, because I think there's no cutoff bilirubin that I am aware of, to be honest, because we are dependent on our surgeons. If the surgeon says, I'm not going to operate on this patient with a bilirubin of 15, then you don't have a choice but to go in and put a stent. And sometimes the patient wants to, think about surgery. One has to remember the results of Whipple's are different I'm sorry, but in different parts of the world. The experiences are different. So one has to be very careful when one is actually advocating one modality of treatment or the other. Size of the tumor, by the time, like you said, by the time we get the patients, they're usually pretty late. I haven't seen any patient with T1 or T2 of pancreatic growth. They're almost always 4 centimeters or above quite often. And the one thing that I wanted to also add is that, like Khalid just said, I feel that CT scan is less operator dependent, but EUS is very operator dependent, very nicely shown by people like Khalid and Professor. They are obviously very good. Someone like me, I'm not very sure I'm very good at taking care of, I'm very good at commenting on the vascular involvement in pancreatic disease to the extent where I can say, well, you know what, I can challenge the CT scan. And so hence we also feel that, here in our part of the world, we tend to be more dependent on CT scan if it is done properly and reported properly. I understand there is variability there as well.
In Egypt, surgeons ask for CBD stent before surgery if the bilirubin is more than 12 milligram %, or if there is cholangitis. But if it is no cholangitis and the bilirubin is below 12 milligram percent, then they go for surgery and spare or avoid ERCP. This is the usual practice in Egypt.
John, you wanted to say something?
Yeah, the data on the bilirubin came from that Cohen study, didn't it, from the guys in the Netherlands? But it was basically picked out of the air. So they used the same as it was 300. I can't remember what that is in the milligrams per mil, but they picked 300, and they said above that you won't be able to enter the study. Below that, you get randomized to upfront surgery versus stent and surgery after, and showed that the stenting was associated with worse outcomes. But that number was not based on anything particularly scientific. They just picked a number and went for it. And unfortunately, that's then filtered down to a lot of our colleagues who now think if it's over that level, that you should then have a stent put in first. What we don't actually have is great data on what happens. There's a little bit. So Keith Roberts from Birmingham's done some work on upfront surgery in Aberdeen, where he used to work. Basically, if the patient had good renal function and was fit, it didn't matter what the bilirubin was. So if they were fit enough for surgery and their renal, because the renal function you worry about, if the renal function is reasonably okay, hasn't completely ruined their clotting, then they would take them to theatre with, didn't matter what the bilirubin was. And interesting, we always talk about cholangitis in tumours. I don't know what most people's experience is, but if you can't get something at the level of a molecule out through a stricture, you're not going to get something the size of a bacteria back up it. The most common cause of cholangitis in cancer patients is when someone's bumbled an ERCP. So we've got in, put a bit of contrast in, haven't got decent drainage, and we've then infected what was a sterile system. Most ducts that get cholangitis are the ones with stones in, i.e. they're already dirty and then they get obstructed and then they get infected. So, we often get pressured by people, oh, they're going to get cholangitis. Like, no, they're not. Or it's not that common that they get cholangitis. There's more time. I think what Professor Okasha has said is really valuable. There's plenty of time to think, right, okay, their bilirubin is 5, 10, whatever it might be. Get the right information so you're doing exactly the right thing for the person. Don't have the pressure to get, unless it's really clear they're not going to have surgery, then don't just leap into an ERCP. We did a study showing that the stents get in the way of staging, and they definitely get in the way of getting a decent biopsy. So all of the things that you want to know get ruined by putting a metal stent in if that's the first thing you do. So if you've got time, which you have, look at the staging, do a PET scan. We do PET scans now a lot in the UK. They're very, very useful. Get an EUS prior to the ERCP, and if you can, do EUS and the ERCP in the same sitting. So we bring them down to the department, do an EUS, do the staging, do the biopsy, switch to ERCP, do brushings and a stent, and then they've had everything done, and we've done it without the tumour being messed with first up, which I think is really useful and fantastic talk. Thank you very much.
Great.
That is very true. Like these patients with a mass malignant obstruction, they don't develop cholangitis unless there is an instrumentation or there is a stone there. They do not have cholangitis because of the malignant obstruction. That is very true.
So with these clear messages, I think if there's no more comment, no more question, it remains for me to thank Professor Okasha for a wonderful presentation, for a wonderful interaction. And similarly, thanks to all the panelists, thanks to all the attendees who have spent the time to make this program successful. I'm also thankful to Wilson Pharmaceutical for providing the platform. So see you next week. Take care. Allah Hafiz. Bye-bye.